So I have no disclosures with this talk. So, arthrodesis is really the gold standard for any end-stage arthrosis. We do this all the time, right, for foot and ankle surgery. We also take care of a lot of non-unions, and we know a lot of bones are actually prone to get non-unions. And we also know that non-union rates for fractures, as well as even for arthrodesis, can be as high as 40%, and sometimes, depending on the joint, maybe even a little bit higher. So, multiple factors associated with non-unions, whether it's a fusion or fracture, smoking, diabetes, alcohol use, avascular necrosis, on and on and on. And ideally, looking for the graft to support healing response is the goal of forming a good union. That's what we're all after, right? We want our patients to heal. We want them to get a good fusion. So, options for autologous bone grafting. Iliac crest, it's probably the gold standard, and I think that that's what the majority of us that are a little bit older trained on. But other ones, tibia, calcaneus, those are all good areas that you can get some really good, metaphyseal bone, good cancellous bone. And really the gold standard of bone grafting is not allograft, it's autologous bone grafting, because it really gives you the osteoconductive, osteoinductive, and osteogenic properties that you're looking for bone grafting. So when you look at this, and you're comparing the two between autograft and allograft, and I would say, we've basically, because of the morbidity, a lot of us have transitioned to using a lot more allograft with our fusions, but really it's not osteogenic. The nice thing about it, though, is that you can get as much volume as you want to. You can get the large, you can get the jumbo, you can get whatever your rep is selling you for a ton of money. And there's really no donor site morbidity. And it doesn't take any time, and really there's complications that are associated with it. So really what you're after, the allograft is nice and easy, and that's why we've all transitioned to it. But really still, I think there's a role for autograft for a lot of these patients. So if you look at some of the studies, again, donor site complications, as high as close to 10%, and these include infection, prolonged wound drainage, hematomas, need for reoperation.